I'm going to be speaking to you today about how you can use Renal EDE or POCUS to optimize care of the renal colic patient. Many thanks to Andrew Skinner, who created the Renal EDE chapter and module from EDE 2. Andrew is responsible for launching the POCUS programs at St. Paul's NVGH in Vancouver, and he's also an excellent barber. Before I can go further, I need to mention some conflicts of interest. First off, I am director of the EDE 2 course. I am also chief editor of Essentials of Point of Care Ultrasound, the print book and ebook, and I'm also in charge of EDE Online, which we are launching this year. Here are the objectives for my talk. Knowledge. Describe the steps for performing renal EDE and the elements used to interpret the scan. Comprehension. Discuss how the results of renal EDE affect clinical decision-making and ED flow. And application. Identify strategies for integrating renal EDE into the evaluation of patients with possible renal colic. I just wanted to highlight that you, the audience, have different backgrounds and work in different settings, so your objectives may vary. Some of you may be physicians working in large urban community emergency departments with 24/7 access to labs and CT scan with elective ultrasound available until 11 p.m. Others may work in a small rural ED with labs and x-ray available only until 8 p.m., elective ultrasound only available during the week, and no CT scan. Also, I am assuming a wide range of POCUS experience, from none all the way to the advanced user. I think this presentation will be useful for everyone. Let's start it off with a case. A 21-year-old man presents to triage with the chief complaint of sharp left flank pain, which has been intermittent for 5 days. It's now worse for the last couple of hours, and his triage vital signs are normal. Further history shows that it's new onset, never had it before. It's more left lumbar, there's no radiation to it, and when you ask if it's worse with movement, the patient kind of stretches in front of you to sort out the answer to that question. Review of systems, no fever, vomited 3 times, no stool changes, mild dysuria, cloudy maybe, nothing you're too convinced about, there's no penile discharge, past medical ADHD, meds and allergies negative, he's got a physical job, no sex for the last 6 months, and he smokes some pot. On physical examination, vitals again are normal, rest of the exam is fine actually, and abdomen's non-tender, back's non-tender, there's no CVA tenderness, and in the legs, forced light touch, straight leg raise, all normal. And some tests that were done at triage are already back. Creatinine's normal, and the urine showed 11 to 20 red blood cells per high power field and 6 to 10 white blood cells per high power field. So, after your history and physical, the differential diagnosis is already boiled down to MSK back pain versus renal colic, with urinary tract infection being less likely. What would be a typical workup in many emergency departments for such a patient? First, the patient gets triaged, which commonly includes the initiation of blood and urine tests by protocol. Then, the patient has their initial assessment by the emergency physician. On a good day, that might involve a 2-hour wait. In many cases, both an elective ultrasound and a CT scan are ordered. Sometimes only an ultrasound is performed. In other cases, only a CT scan is done. Regardless, these tests take a long time to get done, extending the workup by many hours, sometimes an entire shift. What does this mean for the functioning of your emergency department? What if every length of stay became the 6-hour length of stay of the renal colic workup? And what if you extended the 6-hour length of stay to all patients? Here's what that would mean for ED flow. This is a time-lapse animation of the 6-hour length of stay emergency department. Patients come and they don't go. They stay and they stay and they stay. Only a few leave. Before you know it, your waiting room and ambulance bay are backed up, and you have almost nowhere to see new patients. But what if we instead insert renal POCUS into the management? You can convert many such cases into one-touch medicine and drop the length of stay by several hours. Now, renal POCUS won't eliminate the need for a CT scan in 100% of patients, but in many cases it will. The result will be to drop the length of stay in many rule-out renal colic cases to 2 hours. How would flow change in the emergency department if the average length of stay was decreased to 2 hours? Your ED would actually flow. Some complicated patients would still stay for a while, but more patients would be discharged quicker, allowing for space to see new patients. What about the smaller emergency department? This is a map of northeastern Ontario. There are many small hospitals in the northeast with limited resources. Thanks to the push for TPA and strokes, some are now getting a CT scanner. Like any new toy, its presence can drop the threshold for using it. It is the best test for renal colic, but just because you can now easily get a CAT scan does not mean you should use it all the time for renal colic patients. Of course, the main reason to still avoid its use is the neoplastic risk of radiation. This is especially the case in younger patients. In the smaller hospitals without a CT, POCUS makes life so much easier, especially in off hours when labs and imaging are closed and only available on a call-in basis. How do you do renal POCUS? Well, if you've done the EDE course or another intro course and learned abdominal EDE or the FAST scan, you pretty much know how to do renal EDE. The steps are identical. The only difference is the area of interest. In renal EDE, we are not interested in the interface, we are interested in the kidney. Let's quickly review the steps. Step 1 is probe placement. The probe is placed in the longitudinal plane along the posterior axillary line at the level of the xiphoid process. As always, the indicator is directed towards the patient's head or cephalad. At step 2, slide the probe anteriorly and posteriorly to locate the kidney. Because the initial probe placement has the probe cephalad to the kidney in almost everyone, at step 3, you then need to slide the probe caudad to center the kidney. Once the kidney is centered, you need to magnify it by decreasing the depth at step 4. Then at step 5, it's time to sweep your area of interest. To this point, we've been focusing on the kidney, but more specifically, the area of interest is the collecting system, that area of white in the center of the kidney. As you sweep the kidney, you'll be looking for hydronephrosis. That's the main positive finding in renal colic patients. There are other positive findings to look for, such as stones, but we'll restrict ourselves for today to the main positive finding, hydro. When a patient has hydronephrosis, there is too much black seen within the collecting system. Before going further, let's put everyone on the same page in terms of the anatomy of a normal kidney on ultrasound. First, let's work on orientation. The indicator is directed cephalad. Of course, the indicator is on screen left, so there is cephalad. Screen right is therefore caudad. The probe is on the lateral surface of the body. Since the probe is always at the top of the screen, there is lateral and there is medial. Here is the renal capsule, there is the cortex and medulla, and there is the white collecting system. Here is what severe hydro looks like. Only a small minority of patients have severe hydro, but it makes a good place to start because it's so easy to see. Here is the cortex and medulla. Here is the white of the collecting system. Here is way too much urine trapped in the collecting system. If hydro has been present for some time, the cortex and medulla can start to thin. This image jumps off the screen. The kidney looks like a balloon. Here is what moderate hydro looks like. Only a minority of patients have moderate hydro. All of the calyces are quite distended, and there is a wide channel connecting them. Moderate hydro is easy to see. The distinction between moderate and severe hydro is blurred. In any case, the result is treated the same. It's a positive scan. And it's a data point that is going to increase the chance of proceeding with a CT scan and urology follow-up, or at least definite follow-up with the emergency physician or repeat imaging. Here is what mild hydro looks like. Most positive scans will show mild hydro. The KLSEs are starting to dilate, but during the sweep there is either no connection seen between KLSEs or only a thin black line that connects them. If you are ever uncertain about whether mild hydro is present or not, just scan the other kidney to compare. If both kidneys look the same, the scan is normal, but if they are different, then mild hydro is present. How does your renal EDE result help you? In two ways: diagnosis and prognosis. In a case like the one I presented, where the diagnosis is unclear, a positive scan will usually help clinch the diagnosis of renal colic. Here, all you need is a binary result, positive or negative. Elective ultrasound and POCUS will be positive around 70% of the time for hydro or stones. It will be negative in about 30% of cases. There, you will be relying on your history, physical, and other tests to make the diagnosis. On the other hand, if a patient shows up with characteristic pain, a past history of renal colic, and lots of red blood cells in their urine, you don't need imaging of any kind for the diagnosis. You have the diagnosis. It's renal colic. But the renal EDE result can be added to your usual list of red flags, including fever, elevated creatinine, persistent pain, etc., to help further guide management. No hydro means a less than 1% chance of intervention. Moderate to severe hydro means at least 5 to 10% chance of intervention. In terms of mild hydro, the risk of intervention is controversial. Without getting too far into the weeds, no study or consensus document has ever defined what mild hydro is, so the studies aren't too reliable. We have created a more precise definition at EDE too, but it's never been put to the test in a study. Just a reminder to use all data points to come up with an impression. Hydronephrosis suggests a renal stone, but only if your other data points suggest a possible stone as well. Otherwise, the hydronephrosis may have another cause. Let's return to our case. Here is the patient's left kidney, which was on the same side as his pain. In the first few seconds, you decide if there's hydro. Then some markers will show you if you're right. Here's the kidney. There's the collecting system. The red arrows are showing you hydro within the collecting system. The white arrow is showing you a renal pyramid which is outside the collecting system. Only look within the collecting system. That's your area of interest. Here's the right kidney on the unaffected side. As you can see, there is almost no black within the white. So the scan on the left was positive for mild hydronephrosis. Let's finish up the case. The patient was seen 1 hour 20 minutes after registration. Their blood and urine tests were already back. Between that and renal EDE, the patient was diagnosed with renal colic at first touch. They were given a shot of ketorolac and were better at 45 minutes. At that point, they were discharged with a prescription for ketorolac and tamsulosin and PRN follow-up if they were not completely pain-free in a few days. The total length of stay was just above 2 hours. The patient did not return to the emergency department. Because I knew I was going to use this case in my presentation today, I contacted the patient 1 month later to confirm that his pain did indeed resolve completely after a couple of days. Let's go through a couple more cases to see how renal POCUS can aid management. A 41-year-old man with a past medical history of renal colic presents with characteristic right flank pain for 2 days. He has normal vital signs and no tenderness on exam. His pain is already better with ketorolac given at triage. His blood tests are normal, and he has 50 to 100 red blood cells per high power field in his urine. There are no red flags. What's the diagnosis? Of course, it's renal colic. You don't need any imaging to tell you that. But you put the probe on to look for hydro. Do you see any hydro here? Nope, there's no hydro. That does not rule out renal colic. That's still your clinical diagnosis. But now EDE has added one more prognostic data point to say that it's reasonable not to push things further. Maybe the patient does not need that CT scan. Maybe that patient does not need urology follow-up. After all, the patient himself knows it's a kidney stone. He just wanted to get his pain under control and to get a prescription. He's likely a patient who is willing to come back to see you in a few days if his pain is not better. But probably it will be better. Now, change the scenario to 2 weeks of pain and not just 2 days, then that does buy the patient a CT scan. The duration of pain alone is a red flag that makes you push further. Here's a different case. A healthy 47-year-old woman presents with a 3-day history of frequency, dysuria, and left flank pain. She has had a few UTIs in the past. Her vital signs are normal, and she has mild left CVA tenderness. Her blood tests are normal. Her urine shows 50 to 100 white blood cells and 10 to 20 red blood cells. You are about to send her home on antibiotics, but then because her pain seems a bit worse than the average pyelo, you decide to put the probe on, and here's what you see. So, obvious hydro. This totally changed management. Instead of sending her home on PO antibiotics only to bounce back in the next couple of days, she gets admitted for definitive management of her stone and secondary pyelo. I've seen quite a number of cases like this over the years, a couple of whom became frankly septic a few hours after I admitted them. And did you notice something else in this video? Good on you if you did. You can see it right here, a UPJ stone. There are a number of caveats for renal EDE. I'll mention a few of them here. A small minority of patients can still have a ureteral stone despite the absence of hematuria and no hydro. What's going to tell you to still pursue the diagnosis of renal colic? Your history, your physical, your past medical, clinical suspicion rules. Don't forget there are multiple other causes of hydronephrosis. Extraureteral masses, bladder tumors, AAAs, the list is endless. Keep that in mind before concluding that the hydro you're seeing is from a stone. Last but not least, be cautious about integrating renal EDE into your decision-making before you fully climb your learning curve. You can check out POCUS.ca for more information. Just to sum up, in terms of knowledge, we know that the steps for completing a renal EDE scan are the same as those for abdominal EDE. We now know that the main positive finding is hydronephrosis, where there is too much black within the white of the collecting system. In terms of comprehension, we have reviewed how renal EDE can help with both diagnosis and prognosis. We have discussed how renal EDE can help decrease length of stay and improve patient flow in a subset of patients. Lastly, we have only touched a bit on application. If you are going to make maximum use of renal EDE in kidney stone patients, you'll want to decide to pick up the probe from the get-go, right from when you read the triage note. If you do not do your scan at first touch, you're just less likely to use it. Culture is important. If you work in a big shop where all renal colic patients see urology and follow-up, and the ticket to the urology clinic is a CT scan, that's going to create some challenges. And of course, you need to learn how to do the scan. There's plenty of options for learning, including online courses and boot camps, and there's plenty of free stuff on YouTube. I am sure many of you listen to EM cases. There were 2 episodes on acute kidney injury a few months ago. POCUS came up more than once, especially with respect to ruling out a post-renal cause of kidney failure. And guess what? The most important finding there is the one we discussed today, hydronephrosis, usually bilateral, so you can check that out. In fact, let's present a quick case related to Anton's podcast on AKI. This was a man in his 60s who presented with shortness of breath for 2 weeks. Cardiac EDE showed normal LV contractility. Lung EDE showed bilateral B lines dependently. And while being scanned, he started to complain of symptoms of prostatism. So renal and bladder EDE were performed as well. His bladder was huge, and this is what both kidneys looked like. As you can already recognize by now, this patient had obvious bilateral hydro, so the treatment for his CHF was not nitrates, not furosemide, it was a Foley catheter. His creatinine came back at over 1,000. So, very useful to sort out your patient's diagnosis at the bedside when you first assess them. Why wonder when you can know? Lastly, we are debuting EDE Online this year. It includes all of the content from EDE 1 and EDE 2 with content from EDE 3 to come. EDE Online combines the EDE ebook, EDE 1 and EDE 2 online modules, and the newly released EDE smartphone app. You can register for access on the EDE 2 website via the online offering that has been posted in association with NOVEC. More info about EDE Online will be posted on the edeblog.com. If you have any questions about EDE Online or anything else related to POCUS, feel free to email me. And that's it. On to the questions and comments part of the session.